Okay, good afternoon or evening, depending on where you are in the country. This will be a webinar on the medical and nutritional approaches to polycystic ovarian syndrome, which will be called PCOS. I'm Dr. Friedman, and I'll be assisted today by Angela Grazie from Pennsylvania. I will mute everybody's phone, and we'll use the chat button for questions. We'll probably do the questions all at the end. PCOS is a common condition. It's probably the most common endocrine disorder among women. It affects 7 million women. That's more than the number of people diagnosed with breast cancer, rheumatoid arthritis, multiple sclerosis, and lupus combined. PCOS is a complicated and multi-systematic disease. Some of the things that it can affect, including the head, it can give male pattern baldness and depression. I haven't seen that much dandruff. It can give extrafacial hair and coarse hair growth and masculine features. It can give dry patches of skin, such as on the back of the neck, called acanthosis, and also cystic acne. It can give weight gain. It can give thickening of the wall of the uterus, polycystic ovaries with multiple cysts seen on ultrasound. These ovaries, the cysts in these ovaries can rupture and be painful if they get large enough. One of the main symptoms is irregular menses, and it's also quite a common cause of infertility, probably the most common cause of infertility. The causes of PCOS are really unclear, and when I was a fellow at the NIH about 30 years ago, we were taught that there's different causes, including problems with the GnRH pulsatility function in the hypothalamus. It also can be a pituitary problem with problems with LH and FSH in the pituitary. It's an ovarian disorder. The follicles do not mature, and an adrenal disorder where there is also improper ratio between estrogen and testosterone. The high testosterone can lead to the acne, male pattern baldness, masculine features, and facial hair. It's also, most importantly, a disease of high insulin and insulin resistance. This can be both a consequence of weight gain and can possibly lead to weight gain. It can give to that acanthosis skin patches that we talked about, and can give fungal infections. So therefore, it is quite a complex disease that affects a lot of the systems in the body. There are different definitions of PCOS that I thought would be interesting to go over. The first one came from the National Institute of Child Health and Human Development in 1990. That has to have the patient having clinical and or biochemical signs of hyperandrogenism, which is high testosterone, and also either oligo or no ovulation, excuse me. In 2003, the Rotterdam guidelines from the European Society said 2 or 3 criteria: oligo or chronic anovulation, clinical or biochemical signs of hyperandrogenism, and they include the polycystic ovaries. Then in 2006, the Androgen Excess Society, of which I'm a member of and was involved a little bit in the guidelines, demonstrated that the patients have to demonstrate both hirsutism and or hyperandrogenism and oligo anovulation and or polycystic ovarians. And in all the guidelines, you have to exclude other causes of androgen excess and other causes of lack of ovulation and infertility. And you can see there's a lot of vagueness in this. Do you have to have the polycystic ovaries? Do you have to have 3 things or 2 things? Do you have to have blood tests or just clinical signs of high testosterone? So there's a little bit of vagueness in this diagnosis. In terms of the diagnosis of PCOS, endocrinologists place more emphasis on the high androgens, especially measuring the androgens, and also on the insulin resistance. Gynecologists place more emphasis on the pelvic ultrasound. There's this characteristic string of pearls seen on the ultrasound, and some gynecologists don't even measure testosterone levels. Polycystic ovarian syndrome has probably several etiologies: ovarian, adrenal, pituitary, and hypothalamus, and it has different gradients from mild to severe. So there's going to be some controversy about whether you have PCOS, what the type is. People ask me, do I have it? And I try to give them my best guidelines of whether they have it or not. But it's basically based on lab tests and the clinical scenario. PCOS is part of the metabolic syndrome, which includes insulin resistance, abnormal lipid measurements, obesity, and high blood pressure. It may be harder to lose weight if you have PCOS. but weight loss and diet are crucial for the management of PCOS. And Angela's going to talk about that. There's a lot of long-term health consequences of PCOS. These include the high insulin and insulin resistance, impaired beta cell function, increased risk of diabetes, obesity, and high lipids. The general consequences include increased cardiovascular risk. So having PCOS is an increased risk factor for having heart disease. There's also increased risk factor, especially if untreated, of endometrial cancer. There's certainly reproductive consequences of PCOS. These include the increased prevalence of menstrual disorders, the high testosterone, trouble with ovulation induction, requirement for higher doses of ovulation induction, high prevalence of miscarriages, and a higher prevalence of pregnancy complications, including gestational diabetes. As the definition said, you need to exclude other causes of androgen excess and irregular periods. Certainly the one that people who come to see me are the most familiar with is Cushing's syndrome. We'll talk about how you differentiate that from PCOS shortly. A prolactinoma can give you irregular periods and slight androgen excess. Menopause or perimenopause can certainly give you irregular periods, although not typically androgen excess. And a condition called congenital adrenal hyperplasia, where you have blockage of the enzymes that make cortisol. This can lead to high testosterone and high of some of the cortisol precursors that leads to excess hair growth and irregular periods. I think the key symptoms that we mentioned a little bit in that first slide include irregular or no periods, facial hair, acne, infertility, can't lose weight, and hair loss from the top of your head. The laboratory tests I recommend to diagnose PCOS include, the most important one is the total and bioavailable testosterone with a sex hormone binding globulin, or SHBG. DHEAS is also high in PCOS. I recommend measuring that. Sometimes the testosterone can be normal and the DHEAS is high. A day 3 or so LH-FSH and estradiol. Cushing's test, including a 24-hour urine-free cortisol, 11 p.m. salivary cortisols, nighttime cortisols. Prolactin is helpful to measure. 17-hydroxyprogesterone is a test to do to exclude the congenital adrenal hyperplasia. And hemoglobin A1C gives a good balance of pre-diabetes versus diabetes versus normal glucose, and that's usually very helpful to measure. And sometimes they get a fasting insulin and glucose to see how insulin resistant the patient is. Now, the test called SHBG is quite important. Sex hormone binding globulin is a protein that binds to both testosterone and estradiol. Its amount can vary widely in patients, and if the SHBG is either higher or low, the amount of the active, which is the bioavailable form of testosterone, can vary widely. Therefore, I think it's essential to measure the SHBG in all patients being evaluated for polycystic ovarian syndrome. Actually, the assay in women for free testosterone is often inaccurate, so I usually don't recommend a free testosterone, but the bioavailable one is quite accurate. And you can measure the total testosterone, the SHB, and the bioavailable testosterone. It comes as usually a panel, and getting all three of those is quite helpful. So the bioavailable testosterone that I order from either LabCorp or Quest includes what is loosely bound to albumin is what's the active amount of testosterone. It's called the bioavailable testosterone. Often the panel does include the free testosterone, although I don't think it's quite as helpful. The assay is quite accurate when measured at a reliable lab like LabCorp, Esoterics, or Quest. The bioavailable testosterone determines how much active testosterone the patient is actually seeing. And the patient may have a normal testosterone but a low SHBG, which happens in insulin resistance, and therefore they have a high bioavailable testosterone. And this may go along with signs and symptoms of androgen excess, including hirsutism or acne. And I've seen many people that have gotten a normal total testosterone. Their doctor told them it was normal, but they didn't measure the SHBG, and their bioavailable testosterone was quite high. On the other hand, a patient may have a high testosterone and a high SHBG, but a normal bioavailable testosterone. Now, SHBG is reduced in insulin resistance and obesity, and it's really a good marker for insulin resistance. It also can vary with thyroid disease, for example, but it's usually most reflects insulin resistance. Many women with polycystic ovarian syndrome have a high normal or even a normal total testosterone, but a low SHBG because they have this insulin resistance. Therefore, the bioavailable testosterone is often on the high side. I use a cutoff for the bioavailable testosterone of 8 nanograms per deciliter at the LabCorp or Quest assay to diagnose PCOS. And as I mentioned, birth control pills and other forms of oral estrogens raise a higher total testosterone than if the SHBG was normal. These patients often have normal or low bioavailable testosterone from birth control pills. A recent study found that birth control pills can raise SHBG, and even after stopping them for a year, the SHBG remains high. And because the SHBG is high, the bioavailable active form can be low. A patient can also have low libido, and they can also, the estrogen can also be low because the SHBG is as high. The active form of the estrogen is also low. So people can still be misled by having this SHBG be affected because of the oral estrogens or birth control pills. So I think this is some of the reason why people on birth control pills may not feel that well, is their estrogen is actually low and their testosterone may be actually low. SHBG is not affected by transdermal estrogens such as estrogel or an estradiol patch, and it appears that oral progesterone such as Prometrium or Provera may also raise the SHBG, although this is probably to a lesser extent than the oral estrogens. Now, I always try to figure out why somebody, when somebody comes to see me, some of the things I'm thinking about, they have irregular periods or no periods, include hypopituitarism, polycystic ovarian syndrome, or Cushing's syndrome. These conditions, although usually not the hypopituitarism, but the polycystic ovarian syndrome and the Cushing's, can lead to acne and hirsutism. However, the testosterone is usually high in polycystic ovarian syndrome, especially the bioavailable testosterone, while it is low in Cushing's syndrome or hypopituitarism. So for me, measuring the testosterone is crucial. I did publish a paper about 10 years ago that a testosterone level, total testosterone level above 31, done at esoterics, is more indicative of polycystic ovarian syndrome and less indicative of Cushing's syndrome, while the other way around, the lower testosterone is more indicative of Cushing's. A very high testosterone greater than, say, 100 in a modern assay, or DHES greater than 500, could indicate an ovarian or adrenal tumor is worthy of an ovarian ultrasound or adrenal CT or MRI. But the majority of patients have a sort of mildly elevated testosterone. As I mentioned, PCOS is quite common, and most people don't require an additional workup like adrenal CT or MRI or ovarian ultrasound. I use some other hormones to help diagnose PCOS. Get that day 3 LH and FSH. A high LH-FSH ratio is often seen in PCOS. The ratio is often higher than 3 to 1. Estradiol could be low, normal, or high in PCOS. However, a high LH and FSH and a low estradiol are consistent with perimenopause or menopause. High prolactin is consistent with a prolactinoma. High 17-hydroxyprogesterone is seen in congenital adrenal hyperplasia. And high DHEAS is often high in PCOS and usually doesn't require a different type of workup. It's almost always due to PCOS. Okay, I'm going to go over the different types of treatment for PCOS. The Endocrine Society and other societies recommend birth control pills as the first-line treatment for PCOS. There are advantages of birth control pills. They do lower bioavailable testosterone by lowering LH and FSH. They raise the SHBG, so the bioavailable testosterone is lower. The total testosterone, which again is not that important, it looks high, but the bioavailable testosterone is lower, so they work quite well for that. And also, they allow you to have a monthly period that prevents endometrial buildup and helps prevent uterine cancer. However, there's a lot of disadvantages of birth control pills. First of all, they don't improve the insulin resistance, which is the hallmark of PCOS. And the problem with using birth control pills, I find it's really hard to follow the clinical course. The woman gets a period on the birth control pills, but that makes it harder to track to see whether they're really actually getting better with their underlying cause, which is the elevated which is the insulin resistance and the elevated testosterone. Birth control pills do affect liver functions, including this SHBG, which you talked about, cortisol binding globulin, so the total cortisol appears higher, which makes testing for both adrenal insufficiency and Cushing's disease hard. And the thyroid binding globulin is higher also with birth control pills, which may affect somewhat or slightly the treatment for thyroid medicine. Some birth control pills are androgenic, which means they act like testosterone. I often use Dosage, which is my favorite birth control pill, I would say, for PCOS, which has very little androgenic properties. Birth control pills lower the free estrogen, and often leads to a sensation of low estrogen, and this may even lead to menopausal-like symptoms in women, such as hot flashes and night sweating. Birth control pills affect clotting factors that could lead to increased blood clots, so therefore I wouldn't use it. So in somebody over 40, probably in a younger person, that's not that much of an issue. And interesting enough, birth control pills lower the IGF-1, which makes the patient act more like they have growth hormone deficiency. And I think this does happen, especially happens to somebody on growth hormone. They should not be on birth control pills, but even in a person not on birth control, not on growth hormone, it does lower your IGF-1, and that could be detrimental. And then obviously if you're on birth control pills, you can't conceive, so people then would have to stop it and then try to get pregnant afterwards. The drug I use the most for PCOS, and Angela's going to talk a little bit about sort of the consequences of that, but is Metformin. Metformin improves insulin resistance. It can help with weight loss. It helps prevent cancer. It lowers both the testosterone and the DHES and can help regulate periods, although not nearly as much as birth control pills. The disadvantage of Metformin include that it has a lot of side effects, GI side effects, nausea, bloating, gas, diarrhea. These are usually better if the person takes a low carbohydrate diet, and it's almost a conditioning thing. If the person gets diarrhea when they eat a high carb diet, they may try to eat lower carbs. So it seems related very much to the diet. And you can also take Metformin extended release, which has less side effects, and there's some other forms of Metformin that are also like Reamet that are more expensive, but they have less side effects. And it can lead to B12 deficiency. The other drug I use frequently, and I use it frequently in combination with Metformin, is called flutamide. Flutamide is FDA approved for prostate cancer. It is not FDA approved for women with PCOS, although there's thousands of papers published on it, and it works quite well. It does lower testosterone and also blocks testosterone receptor. Unlike spironolactone that I'll talk about in the next slide, it doesn't block aldosterone. It's very specific for testosterone. It decreases hair growth quite well and blocks the action of testosterone quite well. The disadvantage is it's not FDA approved for women. It rarely and reversibly raises liver function tests. So you do need to monitor your liver function test every 3 months. And if they go up more than 3 times the upper limit of normal, you should stop it. And you should not get pregnant while taking it. Another drug commonly used for PCOS that I use somewhat frequently is spironolactone. The advantage is that it also lowers testosterone. It blocks aldosterone, so it is a little bit of a diuretic. So if a person has some edema, it could be quite a good drug for them. It only blocks testosterone at the receptor and not aldosterone like spironolactone, so it's very specific. So it also blocks aldosterone and not testosterone only like flutamide does. The disadvantage is it can raise potassium. It can lower blood pressure and make somebody dizzy on standing and dehydrated. It rarely reversibly raises the liver function test, probably low liver function test, and you should also not get pregnant while taking that, although it's not quite as bad as flutamide. Another interesting treatment for PCOS are the statins. All statins lower testosterone. These include Lipitor, Crestor, Simvastatin, Pravastatin. And then the advantage is they lower testosterone reasonably well, and they also lower your cholesterol pretty well. The advantage is they can increase your chance of getting diabetes, and they have side effects such as muscle aches and decreased memory. So for treatment for PCOS, I often need to use more than one drug in combination. The drugs have side effects, and this points to a need for dietary and supplement intervention, which is where we bring in Angela. So I'm going to bring up Angela's slides next. Where'd that go? Okay, there's Angela. And where did Angela? Here's Angela's slides. Excellent. Okay. So Angela, can you introduce yourself and take it away?
Hi. Hi, everyone. Thanks for joining us this evening. Can everyone hear me okay? Does it sound okay, Dr. Friedman?
Sounds great. Beautiful.
All right. I'm Angela Grazie. I'm the founder of the PCOS Nutrition Center. We're located outside of Philadelphia, but we do provide individualized nutrition counseling to women with PCOS all over. And we also sell many supplements that we're going to talk about today, as well as books on PCOS. So today we're going to talk about nutrition and supplements for PCOS. And a question that I'm often asked is, what is a healthy PCOS diet? How should I eat? There's so much conflicting information on the internet. Should I do paleo, keto, gluten-free, all these different diets, high protein, low carb. And it really comes down to an individualized approach, but I'm going to talk about some specific components to a healthy PCOS diet. And we do know that diet and lifestyle are the primary treatment approaches for PCOS. It can help to optimize labs, improve fertility, and to help maintain weight. So before we go into the foods that we should be eating, I do want to talk about some foods that we should maybe stay away from that can make PCOS worse. And we have to, when we think about PCOS, we're also thinking about inflammation, that it is a state of a low-grade inflammation. So we do see that certain foods can actually worsen that inflammation, and in turn, it can actually worsen the insulin resistance and a lot of the symptoms that we see with PCOS. So, for example, when we think of foods that are very processed, so that means they're broken down into small particles, and those enter our bloodstreams right away, and that causes a big surge in insulin. So the cereal aisle, most cereals, pretty much all of them are pretty refined. They don't have a lot of fiber or have a lot of sugar added to them. White bread, white rice, same kind of effect, quickly rises insulin levels. Baked goods, crackers, candy, sugary drinks, again, quickly enters the bloodstream and will raise insulin. And then this will only contribute to more inflammation. So trying to avoid these as much as possible is really important as a healthy part of a PCOS diet. It's just a little slow advancing.
You see it on yours? Nope, you don't see it yet on yours?
No, is it on yours?
Yeah.
Okay, yeah, I don't see it.
On your computer? Angela, do you have them on your computer?
I still have the inflammation slide up. Yeah. Oh, I have them on my computer, yeah.
Okay, do you want to pull them up on your computer and I'll give you the ball?
Sure.
And you can run it off your computer.
Let's see where we are. Okay. Can you see them on there at all?
Let me make you the presenter.
Okay.
I will also try to move to a little better Wi-Fi place. That will help.
Oh, they just advanced.
There we go. Okay. Now, do you have it on your computer?
I can pull it up right now. Do I have to do anything or just from current slides?
So share your screen. Do share your screen? Or you could see them on your computer and just I'll just what. See, do you have a? Did you share the screen?
I don't see the share screen.
Okay, let me go back to me then. Okay, you see my screen now?
Do you see my slides up?
Go back to my screen. I went back to my screen. No, you should, no, you're just there. Okay, let me see.
We're good?
Yeah, we're
Okay. So we want to focus on healthier carb-containing foods, and that includes whole grains, fruits, vegetables, including both starchy and non-starchy vegetables. Those are carbohydrates as well as beans and legumes. So a lot of times I'll hear fruit's not good for PCOS, you know, you shouldn't eat fruit, and that's actually a myth because fruit has a lot of the vitamins and minerals that can help bring down insulin. And fruits contain a lot of antioxidants, which is important to fight the inflammation in PCOS. But it is important to note they are carbohydrates, and it's important to have them in moderate amounts and spread out evenly throughout the day. So you don't want to have all your carbs at once. And it's important to balance them out. So when you have a carbohydrate food, you want to always have protein and fat at your meal. And the benefit of that is it's going to help keep your blood sugar levels stable throughout the day. So planning a healthy PCOS diet, it's important to start the day off with a high-protein breakfast. If you don't eat breakfast, we do find that even having something in the morning, a handful of nuts, hard-boiled egg, can help keep your blood sugar stable. It's important to eat regular meals and snacks throughout the day, and again, including the protein, fat, and carbohydrates at meals and snacks. Focus on the unprocessed whole foods, including a rainbow of fruits and vegetables. And as far as the portions of carbs, maybe keep them to about a quarter of your plate. And then make half your plate vegetables, another quarter should be protein. So this is an example, not a very pretty example, but it's a basic example of how your plate should look. So I want to go into supplements for PCOS. There's many reasons to take supplements. They can help to improve labs. For instance, insulin can help with cholesterol, lowering triglycerides. They can improve ovulation and quality. Sometimes they can be used to replace nutrients that are missing in your diet. That could be due to a malabsorption issue, or maybe you don't eat that certain foods in your diet and you have to make up for it with supplements. And it can also be helpful to optimize nutrient levels. So the first supplement I'd like to talk about today is B12. We do have good data now that taking metformin can actually affect the absorption of B12. In the diabetes prevention outcome study, we looked at individuals who had impaired glucose tolerance, and they looked at their levels of B12 both at 5 years and then again at 13 years. And what they found at 5 years is that 4.3% of those individuals had low levels of B12 and 19% had low borderline levels. The level that they're considering to have that low borderline is still under 300, and we actually see deficiency symptoms start as early as 400. So even that is a significant issue. And then at 13 years, the number went up to 7.4% had low B12 levels, and then 20% had low borderline levels at 13 years. And we do have some data to show how metformin affects PCOS. That the higher the metformin dose, the more deficient people were in B12, and that metformin can reduce B12 concentrations in as little as less than 3 years, with one study showing that serum B12 levels declined and reached significant lower levels even after 6 months of treatment, and that's taking about 1,500 to 2,500 grams of metformin daily. So what to know is that metformin can cause alterations in the vitamin B12 intrinsic factor complex This is in the ileum, so we need the intrinsic factor in order to absorb B12, and it seems to interfere with this mechanism in the small intestine. We do see that a B12 deficiency is progressive over time in metformin users. B12 is something you don't want to mess around with. Having a deficiency of B12 can cause a lot of mood changes, can make you tired, and can cause permanent nerve damage that can be irreversible. So it is recommended if you take metformin that you just have your B12 levels checked annually. Again, we like to see optimal levels at least over 400 and supplement with B12. And depending on how your B12 levels are, you might need more B12. Sometimes just taking a multi might not even be enough to keep B12 levels up in people who take metformin. The sublingual methylcobalamin form is best absorbed. This is a form of B12. When we think of sublingual, that means you take it under the tongue. So it's usually like a lozenge tablet that just dissolves underneath your tongue, and it's best absorbed that way. Moving on to another supplement known as N-acetylcysteine. This is also called NAC for short. This is a powerful antioxidant. It's also an amino acid. And it's a derivative of L-cysteine, which is a precursor to the amino acid glutathione. So it's important in helping with inflammation. It can also help with insulin resistance. It can help with infertility. It can help lower androgens. Even can help with cholesterol. It's been known to help with oxidative stress. For a long time, it's always been known as a treatment for bronchitis and to help with the immune system. In fact, it's widely sold in Europe to help with the common cold. Recommended dosage is 1.6 to 3 grams daily. However, there are some studies that have shown that obese women would need more than 3 grams a day to be effective. And really, side effects are hardly there, very minimal. If anything, it might cause a little bit of low blood sugar, which can happen with any supplement that is aimed to lower blood sugar or insulin. I do sell a form of NAC at the PCOS Nutrition Center, so you can visit our store at pcosnutrition.com and check that out. We do have good data on NAC in women with PCOS. So we saw that NAC improved BMI, total testosterone, insulin, and lipid levels in women with PCOS. Compared to a placebo, NAC had significant improvement in pregnancy and ovulation rates. And compared to metformin, this is a surprise. Several studies have shown that NAC it can equally work as well as metformin in regards to improving pregnancy rate, spontaneous ovulations, menstrual regularity, and insulin resistance. If anything, NAC improved cholesterol slightly more than the metformin did. So vitamin D is it's a vitamin. It's also a hormone that's usually low in a lot of women with PCOS, and it affects fertility. So we do know that when you take vitamin D, it does help to improve ovulation and egg quality. We see that in this first study that women with PCOS had a higher number of dominant follicles and improvement in their menstrual regularity when they took metformin as well as high doses of vitamin D, compared to just taking the metformin by itself. So we do see that vitamin D helps with more mature follicles. We do see that vitamin D supplementation can actually lower abnormally elevated serum AMH levels as well. Going on to fish oil. Fish oil is one of my favorites because it improves almost every aspect of PCOS. If you have high triglycerides, fish oil is really good at bringing down high triglycerides. If you have fatty liver, fish oil is great for that. It's certainly important for fertility and pregnancy, can help with depression, and can even help with skin and hair health. It's important for cardiovascular health. Fish oil can help to decrease inflammation. And we're looking at an amount of anywhere from 1 to 4 grams daily, depending on your labs. For example, people with very high triglyceride levels, they would need that higher end, whereas someone that has pretty normal levels of triglycerides can get by with about 1 gram a day. So when you're thinking about fish oil, you really want to purchase a high-quality brand. If you buy high-quality fish oil, it's not going to give you that fishy taste. So if you had bad experiences in the past with fishy taste or fishy smell, that means it wasn't good fish oil. And you want to look for brands like the Nordic Naturals that is independently tested. So that means a nonprofit organization tests it for purity and accuracy of what's in that bottle. And again, we do sell this at the PCOS Nutrition Center. Another one of my favorites is inositol.
Angela, you have, Angela?
Yeah.
Angela? You have the bottle as EPA, DHA. You explain that a little bit and which one's important?
What was that?
You have on this bottle has 650 EPA and 50 DHA.
Right.
What's the difference between EPA and DHA? Which one does our patient want to take?
Right. So there's a couple different forms of fish oil, and there's the EPA and DHA, for example, in this one, and 2 tablets will equal about 1,000. So it's a good idea to have a mix of both. Certainly for pregnancy, we're looking at that DHA being really important, but for women with PCOS, for the cardiovascular health, we're also looking for the EPA as well. So it's good to get a mix. So those two will add up to about 1,000 a day.
Great.
Okay, so going into inositol. So again, this is another one of my favorites. You might have heard of inositol before. In particular, there's 2 forms. There's myo-inositol and dichloroinositol. These are pseudovitamins, so they're not exactly a full vitamin, but they act like a vitamin. And they're relatives of the B-complex vitamins. Inositol is widely found in foods like fruit, beans, cereals. Buckwheat is a rich source of it. And inositols work as inositol phosphoglycan mediators. These are also called secondary messengers. And what they do is they help to relay the signal of insulin, basically. So a way I explain it to my patients is that when the glucose level goes up, it pushes on a doorbell on your cell doors, because you want the glucose to get into your cells. And what inositol does is it works to make sure that doorbell's working properly. And in PCOS, they actually think there's a defect with the doorbell, and that's why the receptors are resistant to opening. You might have heard the term insulin resistance before, and that's pretty much what might be going on in PCOS. So inositol works as the secondary messengers to pretty much fix that doorbell so that the insulin is being produced at the rate that it should instead of being produced with a lot of it, which usually happens in PCOS. And we also see that inositol regulates the activities of other hormones like follicle-stimulating hormone, thyroid-stimulating hormone, and insulin. So we see inositol helping with insulin resistance. It can help bring down cholesterol. It has been shown to help improve the testosterone, so it can bring down testosterone. We definitely see it helping with fertility, hypertension, weight loss, reducing the risk of gestational diabetes, and improving the egg quality in PCOS. So you can see with all these numerous uses is one of my favorites. We'd like to see, for as far as dosage, a combination of myo to dichloroinositol in a 40-to-1 ratio, and I'll explain why in a little bit. And it's best to take inositol with meals. That's when it's really going to work. You want those doors to open, and that's when you're eating food and your glucose goes up. And again, like any supplement, it might have the potential to cause low blood sugar, but it's really well tolerated, especially compared to metformin. And you can take this with metformin, but it's not going to give you any GI issues like metformin does. So we know in particular that myo-inositol can improve ovulation and metabolic factors in women with PCOS. It can help to improve insulin sensitivity and decrease triglycerides as well as cholesterol. We see that it really can help with ovulation. So a lot of women who aren't getting regular periods, they start taking this and their cycles start to regulate and they start ovulating. And it's really within like 2 to 3 months it can happen. We also see that myo-inositol can improve egg quality, and it's definitely better than dichloroinositol. In fact, there has been some studies that shows that too high levels of dichloroinositol, if you supplement with over 600 milligrams, can actually worsen egg quality and can actually worsen ovarian response. And the reason for that brings us to the Dci paradox, that we know now that the tissues in our body have a myo to dechiro ratio of 40 to 1. In the ovaries, it's much higher. It could be as high as 100 to 1 myo to dechiro. And what's happening is we're learning more about inositol, and myo-inositol gets converted into dechiro-inositol in the body, and that's via an insulin-dependent epimerase. So that's basically an enzyme conversion. And what we see in PCOS is that the ovaries have an enhanced conversion of myo to dechiro, and that's leading to too much of dechiro-inositol being produced and depleting levels of myo. So again, myo is the one that really helps with egg quality and ovulation and bringing down the insulin. So that's what is a theory could cause poor oocyte quality and impaired FSH signaling in women with PCOS, is that too much dechiro is being produced. So we're recommending now that you supplement with a combination of myo and dechiro, but just in a 40 to 1 ratio. And the studies are showing that that's better than just taking myo or dechiro alone, that the combination can improve IVF outcomes, that the combination can reduce glucose and insulin concentrations, and can help to restore hormonal and metabolic parameters even earlier than myo or dechiro by itself. So there's a brand out there that I sell, and Dr. Friedman, you have this available in your office. It's called Inositol. And it's a combined myo and dechiro-inositol supplement, and it's in that unique 40 to 1 ratio that you really want. And again, this can improve insulin sensitivity, it can restore hormone balance, improve ovulation and egg quality. It's a powder, so it's sold in this pouch, and those of you that take Inositol, you might be looking at a different package that you're used to, and that's because this is the new version that's coming out this week. I think I'm the first to announce it. It's very exciting. That Inositol now is going to be sold without maltodextrin, and it's now going to be sold in this pouch. So in the pouch is individual packets, and this is a powder that you mix in water or maybe an unsweetened iced tea. You can put it in hot beverages as well, and let it dissolve. And again, you want to take it with your meals. A lot of my patients also find that it reduces cravings too, and that gets in the way of following a healthy PCOS diet a lot of the times, is that the cravings are just so intense, and taking this twice a day can definitely help with that. And I'm also excited to say I'm going to be raffling off for the new launch of this Inositol, a free Inositol starting Tuesday. If you go to our Facebook page at the PCOS Nutrition Center, from Tuesday, Wednesday, Thursday, and Friday, you can enter to win a free bag of Inositol. And this is sold as a 90-day supply, and that's what we're looking for, because it might take that long to start bringing down the hormones and improving the insulin.
Angela, is this gluten-free?
It is. It's gluten-free. Yep. No soy, no maltodextrin now. Just pure inositol.
You said there was increased conversion from the increased conversion from myo to the DCI. Why do you want to take DCI at all then?
Well, because that's actually the ratio that we see in the tissues, is a 40 to 1 ratio. So we still want to balance out the DCI, and we want to mimic what's in the tissues.
Great.
And that's what they're finding, and the studies seem to work better than either one alone. Yeah, good question. And then lastly, I want to mention Resveratrol, and this is an exciting study that came out. Resveratrol is a potent antioxidant. It's always been known for its anti-aging, anti-cancer, cardioprotective properties. And Resveratrol is actually found in the skin of grapes. It can also be found in berries, red wine, peanuts too. So this study came out last year, and they looked at 30 patients with PCOS, and they either gave them Resveratrol at 1,500 milligrams a day or a placebo pill for 3 months. And the Resveratrol group saw a 23% reduction in their total testosterone levels and a 22% reduction in their DHEA sulfate levels. They also saw that fasting insulin levels dropped by a whopping 32%. So this is really encouraging research. Before you jump to get the resveratrol, this is the only study we have so far in women with PCOS. And again, we do know that resveratrol is an antioxidant, so it can help with inflammation and help with oxidative stress. What is the optimal dosage in women with PCOS is still unclear. In this study, it was 1,500 milligrams, which is a high dose of resveratrol. But it could offer, it doesn't hurt to take it. It certainly will offer other benefits too, like the ones mentioned here. And Dr. Friedman, I believe you sell this in your practice as well, right?
Right. I have a 1,200 milligram dose.
Oh, great. That's great.
Yeah.
So it's worth trying, but we definitely need more studies to really show optimal dosage and more of what it can do for women with PCOS.
Yeah.
So in conclusion, diet and nutrition are the primary treatment approach for women with PCOS, that anti-inflammatory foods, sensible portions, slow carbs can help. Nutrition supplements, when added to a healthy diet and lifestyle, can offer health benefits and help with ovulation. But we know that PCOS is very heterogeneous, so not all women respond the same way, so we need more studies to determine which supplements work best in what types of phenotypes of women. And it's really important to discuss supplement use with your healthcare professional. If you're interested in learning more about nutrition and diet for PCOS, you're welcome to visit the PCOS Nutrition Center website. We have a lot of articles there and recipes. We have the PCOS workbook available, which is a self-help guide that's been shown to reduce anxiety, depression, and problematic eating. We also have recipes in our cookbook. As I mentioned earlier, we do offer individualized nutrition coaching for PCOS, as well as some of those supplements that we talked about today. So thanks for joining us.
Yep.
Do you want to open up to questions?
Yes, that was a great presentation. So I'm going to open up the chat
Okay.
button, and people can type in on the chats. Again, I think it was a really good combination between you have the medical treatments, which work well, but they have side effects, and then you can have these supplement treatments that may have less side effects and may work equally as well, and you could do in combination. So I'm open to my patients to using some of these supplements, and Angela is a great resource for helping you guys out with picking which supplement you want. So please go ahead and type in your question on the chat box. Don't be shy, people.
Someone's asking if PCOS is genetic.
Okay. There we go. Okay, so I didn't get that one. I'll answer that question. Yes, it is genetic. There is a very strong family linkage with it, and if your mother has it, you're a good chance of getting it. If a patient has been previously diagnosed with PCOS but subsequently had a total hysterectomy, how can the root cause continue to affect you? So there is different types of PCOS, including hypothalamic, pituitary, and adrenal. In general, one of the cures of PCOS is removing ovaries, as that's the major source of testosterone. But you could still have some disorders. You can still have, in theory, a high DHEAS from your adrenals that could still be affecting you. Usually the insulin resistance is resolved by your testosterone going down, but not always. So I think you need to address, look at what your symptoms are after the hysterectomy. No one in my family has it, so how did I get it? Shireen asked. It's such a good question. So they may have had subtle forms without, manifestations, and I think we're much more attuned to it now than before. But it's also somewhat probably environmental, somewhat probably lifestyle, and I think it's increasing in frequency. Now, I'm not exactly sure why. Is it because people are, more toxins around, or eating worse, or more overweight? But I think it's increasing. So just because you're, when your family had it, you can still get it. Okay. Natasha asked, and I hope she says this is private. I hope she doesn't mind sharing the chat here. What recommendations do you have to find a doctor who can diagnose and treat PCOS? Well, first of all, I'm doing this webinar because I like treating, and I think I have some good thoughts about it. So I'm happy to see you. Angela, do you work with any doctors on the East Coast particularly? And also, Angela has a lot of resources in her website.
I do, and if you email me, I can help you to find a doctor in your area, but you can also go, I think the Androgen Excess and PCOS Society has like a Find a Doctor now.
Yeah, that's a good point. This Androgen Excess Society, I think, is really good. Okay, so Chris Liam asks, if I'm taking birth control and I'm trying to get pregnant, what should I do? Well, I would probably recommend stopping the birth control pill to try to get pregnant. I'm pretty sure you're not going to succeed by taking it. The idea is, and I'm not sure how I totally agree with this, but when you take the birth control pills, it raises your SHBG and lowers your testosterone. So then if you stop them, your SHBG is still high and your testosterone could still be low, and you can still, when you stop them, you have maybe a little bit better chance of getting pregnant than if you didn't take them in the first place. But I think it's certainly, you want to get pregnant, you're trying to, so I would get off the birth control pills and try some of these either supplements or medicines. Okay, Julian asks, do you find a difference in hormone replacement by using oral birth control pills or something like the NovaRing or shots? Yes, so in general, I'm more of a fan of non-oral forms of hormone replacement like estrogel and patches, and avoiding things like oral estrogens. The oral estrogens that I mentioned affect that SHBG, affects your IGF-1. So there seems to be a lot of detrimental effects of the oral estrogens. Something like NovaRing is probably better. I didn't mention Provera as a treatment for PCOS. It does work fairly well, but you can, it has feedback, so it shuts down your estrogen levels, so your estrogen levels can be low with Provera. I don't recommend those Provera shots. I think they give a lot of weight gain. Natasha asked, do you recommend taking an Inositol in combination with Metformin? I think that's a great combination. Again, watch your B12 level, but I think it's really a good way to go. Do you have a thought on that, Angela?
Yeah, I agree. I mean, if you're already taking Metformin, you don't stop it. You can still take the Inositol on top of it.
Mm-hmm.
They work differently.
Yeah. Other questions? Which one did you guys say was similar to Metformin but less side effects? That was nauseous for 3 months. You could take Metformin extended release, and it has usually less side effects than the Metformin. And you can also try cutting down your carbs. I think most of the side effects occur when you're on a high carb diet or high simple carb diet. And then you might want to try something else like the supplements or flutamide or things like that if you really can't tolerate the Metformin. A lot of people can't tolerate the Metformin. Julian asked, will these slides be available after the webinar? Absolutely. I will post them up on my website. I also recorded the talk, so you'll hear the talk and the slides. Can I take it with birth control? I presume you're talking about Inositol, and I would say the answer is yes on that. Do you agree, Angela?
Yep.
Okay.
It can still improve the insulin and help with the cravings.
Right. So the birth control pills don't really work for the insulin resistance. So the Inositol is excellent for that.
Yeah.
Okay. How is insulin resistance different from diabetes? That's a great question. So diabetes is a combination of 2 problems. One is you have insulin resistance, and then your beta cells in your pancreas make more insulin. And that's okay, you don't get diabetes, but then eventually your beta cells can't keep up with the insulin resistance and you get diabetes. So usually insulin resistance is earlier, you usually have a high insulin level, but it doesn't work well, and then eventually the beta cell can't make enough insulin and you get diabetes. Penny asked, you mentioned that NAC improved testosterone levels. Does that mean it decreases it? Yes, it does decrease it. And Angela, do you want to talk about side effects of NAC?
Yeah, it's really well tolerated. If anything, it might cause a little bit of low blood sugar, but usually it doesn't.
Mm-hmm.
Yeah, and you can take, someone else just asked, can you take all these together? You can.
Yeah. If you can only take one of the three between the inositol, the ovastatol with the inositol in it, and the resveratrol, which would be your favorite one?
Oh, it's hard to say, but most people respond well to the ovastatol.
Yeah, that's what I thought too. Okay.
Yeah. But again, like fatty liver, if you have fatty liver, the NAC is really good for that.
Mm-hmm.
And I have a lot of information about inositol on the PCOS Nutrition Center website.
Mm-hmm. Yes, it's okay to take them together. They also, again, seem to work in sort of little different mechanisms, and it might be good to take them together.
Yeah.
Okay, Julian asks, when taking the supplements together, is it best to take them at different times of the day, or will they be absorbed with taking all the doses at the same time? Angela, what do you think about that?
It is best to take them with food, especially the fat-soluble vitamins like the fish oil and the vitamin D we know absorb better with food. And the inositol, you want to take it with food too, because that's when it's going to help to open up those doors to let the glucose in properly. If you can take fish oil together at once, but it's better to kind of spread them out. The rest of them, like the inositol, you'd want to do, say, one packet with breakfast and then another packet with your dinner.
Yeah, so the metformin, I usually have people either take it with dinner or bedtime. And, you know, it's supposed to be a little bit better tolerated with food. The flutamide, spironolactone, those birth control pills you could take basically any time. Okay, we'll take 2 more questions. Anyone else have questions? Okay. So thanks everybody for joining us. Thank you, Angela, for joining us. I'll post the brief talk on my website. And Julian says thank you for sharing. Zerka says, Penny says thank you. So I think it was a very informative time. Thanks everybody. Yeah. Bye-bye.
Bye.